Okay, let's unpack this. Imagine your body is this meticulously crafted machine, right? Billions of tiny parts proteins all folding themselves into just the right shapes to do their jobs. It's, truly a marvel. But what happens when that process, that fundamental folding goes wrong? When these essential bits misfold, lose their shape, and then clump together, piling up where they really shouldn't? Today, we're diving deep into a really complex and honestly often insidious group of conditions known as amyloidosis. And it's not just one disease that's key. It's a whole family of disorders, all coming from this common critical error in protein threading that can just ripple through the entire body.
Yeah, what's fascinating here, and what you really need to grasp to understand this, like the pros do, is how widespread the impact can be from what seems like such a small error. Our mission for you today is to really master this information. Not just memorizing facts, but truly getting why amyloidosis behaves the way it does and what it means for the body. We'll be, sifting through the latest insights from the medical text, helping you understand the crucial distinctions. Because that understanding, it's absolutely critical for diagnosis and treatment, given the profound effects these conditions can have on, well, almost any organ.
So what does this all mean for you listening? We're going on a bit of a journey here. We'll start with a basic definition, then dive into the surprisingly diverse types. Because knowing the specific type, it's everything. From there, we'll unpack the diagnostic process, which, as you'll hear, is like real medical detective work, high-stakes stuff. Then we'll explore the specific impacts on different organs, common patterns, unexpected twists, and finally, look at cutting-edge treatments and where things are heading. Get ready for some genuine aha moments and maybe some surprising insights that might change how you think about seemingly unrelated symptoms. Okay, let's start right at the core. When we say amyloidosis, what are we really talking about? It's an umbrella term, right? For a group of disorders where proteins misfold. But what does that actually look like? It's defined by this extracellular deposition. So outside the cells of insoluble protein fibers, these fibrils in tissues and organs, think of it like rogue protein clumps forming outside your cells, slowly messing things up, disrupting normal function, kind of suffocating healthy tissues.
That's precisely it. Our bodies are incredibly sophisticated. We have this robust cellular machinery, chaperones, designed specifically to guide proteins. Think of them like expert guides during synthesis and secretion, making sure proteins get that correct 3D shape, their conformation. That exact shape is absolutely essential for function. But when things go wrong, maybe incorrect processing, other factors these proteins can misfold. And that misfolding means they lose their normal function and they start to aggregate or clump together. This can happen inside or outside cells. And it's a bigger issue than just amyloidosis. Lots of diseases like cystic fibrosis, even Alzheimer's, involve this fundamental protein misfolding problem.
Okay, so if protein misfolding happens elsewhere, what makes amyloidosis unique? This is where it gets really interesting, isn't it?
Right. While lots of diseases involve misfolded proteins, in amyloidosis, these clumps, these aggregates, are typically extracellular, outside the cell membrane. And what makes them so unique and damaging is their specific structure. They don't just clump randomly. The misfolded subunits line up into this common, highly organized structure called an antiparallel pleated sheet. Think of layers stacked together. It's this distinct, very stable structure that allows them to form higher order clumps and then eventually those long, insoluble fibrils that deposit in organs.
So it's that rigid, almost crystalline structure that makes them so tough to break down.
Exactly. They're incredibly resistant. And to deepen that understanding, we talk about the amyloid hypothesis. This is a well-supported model explaining the process. It suggests that precursor proteins first undergo some reversible unfolding or misfolding. These misfolded proteins then form small clumps, we call them oligomeric aggregates. Then these join together, forming larger polymers, and finally the insoluble fibrils we see depositing in tissues. But here's the crucial insight, the bit that experts really focus on now. Growing evidence suggests it might be those oligomeric intermediates, the smaller clumps, that are actually the most toxic species.
Really? Not the big fibrils.
Well, the oligomers seem to directly damage cells, maybe by generating reactive oxygen species, triggering stress signals. Then ultimately, yes, the larger fibrillar deposits physically interfere with organ function. They literally get in the way.
Got it. And just a quick historical nugget. You mentioned the name amyloid.
Oh, right. Yeah, it was coined way back around 1854 by the pathologist Rudolf Virchow. He was looking at these deposits under a microscope, used iodine staining, and thought they looked like starch amylum in Latin.
So he thought it was starch.
Wow, he had no idea it was protein, just saw the staining resemblance. Kind of neat how names stick, even when the original idea was off.
Okay, so we've got this foundational understanding. How do we start classifying these different amyloid diseases?
Right, classification is key. Primarily, it's based on the biochemical nature of the specific protein making up the fibril, which protein went wrong. Beyond that, we also classify them based on whether they're systemic, widespread, or localized, confined to one area, and whether they're acquired during life or inherited, and also by their specific clinical patterns, which organs they tend to hit.
And there's a standard naming system, right? The AX thing.
Yes, the standard nomenclature is AX. A for amyloidosis, and X stands for the specific precursor protein in the fibril. For this deep dive, we're mostly focusing on the systemic forms, because they're often the most complex and impact multiple organs. So let's look at some key examples, the ones that really highlight the critical distinctions you need to know. First up, AL amyloidosis. Here, L is for immunoglobulin light chains. This type used to be called primary systemic amyloidosis, comes from a problem with immune cells, clonal B cells or plasma cells, often linked to myeloma or lymphoma. The crucial thing about AL, these light chains can deposit in basically any organ. That's why it's so variable.
Right. AL light chains potentially anywhere. Got it. What's next?
Then there's ATTR amyloidosis. TTR stands for transthyretin. TTR is a transport protein for thyroid hormone and retinol. ATTR is actually the most common familial amyloidosis, meaning it can be inherited. But it can also come from wild-type TTR, the normal protein misbehaving, usually with age. This age-related form is a huge and growing issue.
Wild-type TTR. Interesting. Okay, what else?
Next, AA amyloidosis. AA is for serum amyloid A protein. SAA is an acute phase reactant protein, meaning its levels shoot up during inflammation. So AA amyloidosis typically happens with chronic inflammatory or infectious diseases. That's why it was called secondary amyloidosis. It's a consequence of long-term inflammation.
Makes sense. Inflammation driving protein misfolding.
Exactly. Then there's A2M amyloidosis, from misfolded beta-2 microglobulin. This one's strongly linked to long-standing kidney disease, especially after years of dialysis.
Ah, the dialysis connection.
Right. And just to give a quick example of a localized form, AA amyloid. Amyloid beta protein, that's the one famously found in the brain in Alzheimer's disease, but again, our focus today is mainly systemic.
Understanding these AX types, that's really the first step to thinking like an expert here, isn't it?
Absolutely. It's the foundation for everything that follows.
Right, so that X in AX, it's not just a letter, it's a specific protein, and each one causes a unique set of problems, hits different organs. To really master this, like you said, we need to connect that specific protein to the specific disease pattern. It's more than just names. Let's dig into the key players from Table 112.1 in our source material. Focus on the ones that really tell us something critical for diagnosis and treatment.
Couldn't agree more. Accurate typing, knowing precisely which precursor protein is involved, is fundamentally essential. Why? Because it directly guides the therapy. This is why getting into the details of each systemic type is so important. It's the difference between a vague diagnosis and a truly targeted treatment plan. Starting again with AL amyloidosis, precursor, immunoglobulin light chain. It's primary or myeloma associated, coming from those rogue plasma cells, and its signature. It can involve any organ. That makes its presentation incredibly varied. Now, while it's mostly systemic, it's worth remembering localized AL deposits can occur. Skin, eye, bladder, airways. So it can sometimes be contained.
Okay, and there was another one related to immunoglobulins, AH.
Right, AH amyloidosis, involving immunoglobulin heavy chains, much rarer, but also primary or myeloma associated. And like AL, it can potentially involve any organ, same widespread potential. Then AA amyloidosis, precursor, serum amyloid A protein, this one's secondary, reactive, remember, driven by chronic inflammation or infection. Its primary target, usually the kidneys, but liver, spleen, even the heart later on can be significantly affected.
Kidneys first for AA. Got it.
A2M amyloidosis. Precursor, me-too microglobulin, strongly linked to long-term hemodialysis. Where does it hit? Primarily synovial tissue joints and bones. Think carpal tunnel, joint problems.
Makes sense, accumulating where it can't be filtered.
Precisely. Now, ATTR amyloidosis, precursor, transthyretin. This one's really significant, increasingly recognized. It can be familial, mutant TTR gene, or age-related, wild-type TTR. Its clinical involvement, broad, heart, cardiomyopathy, peripheral and autonomic nerves, neuropathy, but also soft tissues, spine, bladder. You'll hear a lot about this one because of new treatments.
Okay, ATTR is a big one. Heart and nerves plus the age-related angle.
Exactly. And while there are rarer familial types, just mentioning a few highlights the diversity, ApoAI amyloidosis involves apolipoprotein AI, usually hitting liver and kidneys. agial amyloidosis from Gelselin can affect the cornea, vision, cranial nerves, skin, kidneys. And a newer one, ALA-CT2 amyloidosis, leukocyte chemotactic factor 2, causes renal amyloidosis, particularly in Hispanic and Pakistani populations. The key takeaway here isn't memorizing every single letter combo, it's grasping the principle. A specific misfolded protein targets specific organs, leading to specific problems.
Right. And beyond these systemic forms that spread, there are also those localized ones, confined impact.
That's right. Important to know they exist. Like amyloid, the amyloid beta protein, Alzheimer's, Down syndrome, central nervous system primarily. AIAPP, amyloidosis, islet, amyloid polypeptide, or amylin. Diabetes associated, found in the pancreas. Affects insulin production. Equiamyloidosis calcitonin, seen in medullary carcinoma of the thyroid. Deposits right there in the thyroid gland. The essential point, the thing to really drill down on. Accurate typing, knowing that precursor protein isn't just academic, it is absolutely essential. It dictates the therapy, it predicts the course. Without it, you're flying blind. That's the hallmark of expert understanding.
Okay, so diagnosing amyloidosis, you said it's like medical detective work, and often a race against time. It sounds really challenging because the early symptoms are just so nonspecific, right? Fatigue, weight loss, swelling, could be anything. So the diagnosis often only comes when a specific organ is already significantly hit, creating this complex puzzle.
That's exactly the challenge, which is why the crucial first step for diagnosis and treatment rests on two pillars. First, you need histopathologic identification, actually seeing the amyloid deposits in a tissue sample, usually from a biopsy. Second, once you find deposits, you need definitive determination of the amyloid type, using immunohistochemical, biochemical, or genetic methods. This meticulous two-step approach, it's non-negotiable for an accurate diagnosis that leads to the right treatment. Knowing you have a problem isn't enough. You need to know which specific problem.
Given those non-specific symptoms, what are the red flags, the clues that should make a clinician think, maybe this is amyloidosis?
Good question. We look for unexplained nephropathy kidney disease, often with lots of protein in the urine, or cardiomyopathy heart muscle disease, especially with that diastolic dysfunction where the heart struggles to relax and fill. Neuropathy nerve damage, affecting senses, movement, or autonomic functions like digestion or blood pressure. Also enteropathy, intestinal disease, arthropathy, joint disease. And then some more specific pathognomonic but less common signs. Macroglossia, that enlarged, sometimes firm tongue, or periorbital ecchymosis, the raccoon eye sign, bruising around the eyes.
Raccoon eyes, wow.
Yeah, it's striking when you see it. But the real key often is the multisystemic nature. When several of these seemingly unrelated things pop up together, that constellation is what alerts a sharp clinician.
So suspicion's high. The next step is the biopsy, the gold standard.
Exactly. We need tissue. The less invasive option first is usually an abdominal fat aspiration. Simple procedure, local anesthetic, use a needle to get a tiny bit of fat from the belly wall. The amazing thing is its positivity rate over 80% for systemic amyloidosis. Amyloid likes to deposit there.
So you can often avoid a bigger surgery.
Often, yes. The aspirated fat goes onto a slide, gets stained. Very neat.
Okay, but what if the fat pad biopsy is negative, but you're still suspicious?
Then, yeah, more invasive biopsies might be needed. Kidney, heart, liver, tongue, GI tract, wherever the clinical signs are pointing most strongly.
And that unique staining property, the Congo red dye test.
Yes, the classic. Amyloid deposits have that very regular pleated sheet structure. When you stain them with Congo red dye and look under a polarized light microscope, they exhibit this unique apple green birefringence.
Apple green.
A distinct green glow. It's beautiful in a pathological sense. Other proteins, like collagen, just look white, so it's a definitive hallmark. You can also see the characteristic 10-nanometer fibrils with electron microscopy. Very high magnification confirmation. Okay, so amyloid confirmed. Now, determining the type. This is where the detective work really heats up, and it's paramount for treatment. Getting this wrong has major consequences. We have several ways to do this. Immunohistochemistry, IHC, or even better, immunoelectron microscopy, uses antibodies. Can point towards AL if deposits bind one light chain antibody. But the real diagnostic standard now is extraction and biochemical analysis using mass spectrometry.
Mass spec, how does that work here?
You often use laser capture microdissection to precisely grab the amyloid deposit from the tissue. Then the mass spec analyzes its protein components, giving you a unique fingerprint identifying the precursor protein. It's incredibly precise. And for hereditary forms, gene sequencing is essential, looking directly at the patient's DNA for the specific mutation. Now, clinical clues, patient history, physical findings, age, ethnicity, organ involvement, underlying diseases, family history, they can provide helpful hints. But, and this is a huge caveat, there's often considerable overlap in how different types present. That's why accurate typing is essential, not just helpful. Essential for appropriate therapy. Cannot stress that enough.
Right. Beyond the biopsy and typing, what about routine lab tests? What do they show and what might be misleading?
Good point. Routine blood counts, usually normal. But the ESR, erythrocyte sedimentation rate, a non-specific inflammation marker, is often elevated. Kidney involvement, very common. Typically proteinuria, often nephrotic range. This leads to hypoalbuminemia, low serum albumin, sometimes severely low 2-GDL, which then causes edema or even anasarca, widespread swelling, cardiac involvement, amyloid cardiomyopathy, key markers. Concentric ventricular hypertrophy, thick walls, diastolic dysfunction, poor relaxation, often associated with elevated BNP or NT-proBNP, and troponin. These are crucial for staging, prognosis, monitoring treatment response in AL. But remember the caveat, kidney problems can falsely elevate these. You have to interpret them in context.
Okay, so you need to know the kidney function too.
Absolutely. Also, other markers like matrix metalloproteinases are being looked at. Specific cardiac imaging findings. ECG might show low voltage with a pseudo-infarct pattern, mimics a heart attack. Echo shows thickened ventricles, that diastolic dysfunction, abnormal global longitudinal strain pattern, the old sparkly appearance, often not seen with modern echo. Critically, poor atrial contractility is common even in normal rhythm, big risk for clots and stroke, and cardiac MRI, very valuable, shows increased wall thickness and that characteristic delayed enhancement after gadolinium contrast. Very specific sign of amyloid infiltration, liver involvement, usually cholestasis, bile flow issue, high alkaline phosphatase, but other liver enzymes, aminotransferases, often minimal change. Synthetic function usually preserved for a while. Endocrine issues, especially in AL if glands are infiltrated, hypothyroidism, hyperadrenalism, maybe even hypopituitarism. So the bottom line on labs, none are specific on their own, but abnormalities across multiple organ systems, that should strongly scream, consider amyloidosis. It's that multi-system picture.
Okay, let's dive deep now into AL amyloidosis, the most common systemic type in North America, you said.
That's right. It usually comes from a clonal expansion of bone marrow plasma cells, a rogue clone of immune cells. These cells secrete a monoclonal immunoglobulin light chain, LC, that misfolds and deposits as those amyloid fibrils.
And it's often connected to other blood disorders.
Exactly. It can occur with multiple myeloma, non-Hodgkin's lymphoma, Waldenstrom's macroglobulinemia. And it's a fascinating question, right? Why do some light chains cause amyloid while others cause myeloma? It seems to depend on the specific amino acid sequence of that light chain, maybe other genetic factors influencing folding.
Epidemiology-wise, you mentioned maybe 4.5 cases per 100,000, but likely underestimated.
Highly likely underestimated, yeah. Usually hits after age 40. And critically, it's often progressive and fatal if untreated. Urgency is key.
Okay, pathology and clinical features. This one's known for its widespread impact, very varied presentation.
Pathologically, yes, the deposits are usually widespread. Found in the interstitium, the space between cells of pretty much any organ outside the central nervous system, explains the variability. The fibrils themselves, full-length monoclonal light chains, around 23 kilea, plus fragments. Other molecules like serum amyloid P, SAP codeposit too. And while kappa LCs can cause it, lambda subtypes are much more common in AL. The lambda 6 subtype seems particularly prone to fibril formation, often in the kidney.
This widespread deposition leads to that pleiotropic set of syndromes, meaning tons of different symptoms.
Precisely. Non-specific stuff like fatigue, weight loss are common early on, but diagnosis often gets delayed until organ-specific symptoms show up, sometimes severely.
Let's nail down the organ involvement details again. This sounds crucial for actually recognizing it.
Absolutely crucial. Kidneys, most frequent, 70–80%. Manifests as proteinuria, often nephrotic range, leads to low albumin, high cholesterol triglycerides, adamanasarca. And the crucial detail, sometimes it's interstitial deposition causing azotemia, waste buildup, without heavy proteinuria, easily missed.
Okay, kidneys very common. Then the heart.
Heart, 50–60% involved, leading cause of death. Critical point, ECG, low voltage pseudo-infarct pattern, echo, thick walls, diastolic dysfunction, abnormal strain pattern, that sparkly look, often not seen now. Poor atrial contraction, clot stroke risk, cardiac MRI, increased wall thickness, characteristic delayed enhancement, very telling.
Nervous system.
Nervous system symptoms, peripheral sensorimotor neuropathy, numbness, tingling, weakness, and/or autonomic dysfunction. Autonomic issues are broad. GI motility problems, early satiety, diarrhea, constipation, dry eye meth, impotence, orthostatic hypotension, dizzy on standing, neurogenic bladder.
Macroglossia, The enlarged tongue.
Macroglossia, classic pathognomonic sign, but only in 10%. Don't rule it out if the tongue looks normal.
Liver, spleen, blood.
Cholestasis, hepatomegaly, spleen. Often involved may have functional hyposplenism, not working well, even if not enlarged. Bleeding. Easy bruising is common due to fragile capillaries from amyloid deposits or deficiency of clotting factor X because it binds to the fibrils.
Factor X binding. Interesting mechanism.
Yeah, and that leads to the raccoon eye sign sometimes. Cutaneous bruising around the eyes. Uncommon, but very specific when present.
Any other signs?
Other findings: nail dystrophy, alopecia, hair loss, amyloid arthropathy, joint issues, thick synovium in wrists, shoulders, causing carpal tunnel. So again, the call to action, a multi-system illness, or even just fatigue plus any of these syndromes, you must think about amyloidosis. Initiate the workup. That's how you catch it early.
Okay, diagnosis specifically for AL. Beyond just finding amyloid, proving it's AL is the goal.
Yes. You need to identify two things. One, the underlying clonal plasma cell or B cell process, and two, the clonal light chain. Now, the diagnostic nuances, the tricky bits. Routine sp2-pep, not good screening tests for AL. Why? The clonal protein level is often too low to make that classic M-spike or Bence-Jones protein.
That's a critical difference from myeloma, right?
Absolutely critical. However, over 90% of AL patients do have a monoclonal protein detectable by more sensitive methods, like immunofixation, SLIFE-UIF, or measuring serum-free light chains, FLCs. And the key with FLCs, look at the ratio, kappa versus lambda, as well as the absolute amount. Why? Kidney failure raises both, so the ratio tells you if one type is disproportionately high, indicating clonality.
The ratio corrects for kidney function.
Precisely. Also, bone marrow biopsy usually shows increased plasma cells, 5-30%. Need to confirm their clonality, kappa or lambda, using flow cytometry, IHC, or in situ hybridization.
And differentiating it, like some MGUS. Monoclonal gammopathy of uncertain significance.
Right. Finding a monoclonal protein alone isn't enough. MGUS is common. But if MGUS is found with biopsy-proven amyloidosis, you must rule out AL. Similarly, someone thought to have smoldering myeloma. If they have kidney, heart, or nerve issues, screen them for AL. Don't stop at the first label. And the final word on typing. Accurate tissue typing is essential. IHC can help. Immunoelectron microscopy is better. But the gold standard now, a laser capture microdissection plus tandem mass spectrometry, directly identifies the protein. In ambiguous cases, rule out other amyloid types with genetic tests, etc. Be thorough. This precision is mastery.
Okay, AL diagnosed and typed. How do doctors assess severity, prognosis, staging systems?
Yes, staging is crucial. The Mayo 2004 cardiac staging system using NT-proBNP and troponins is widely used. European modifications exist for very high-risk patients. Cardiac stage is the biggest survival predictor. The Mayo 2012 system added clonal burden, the DFLC, difference between involved and uninvolved free light chains. Higher DFLC predicts worse survival, independent of heart stage.
So both heart damage and amount of bad protein matter.
Exactly. Boston University also has a staging system with BNP and troponin I. Prognostically, patients with very low DFLC, 50 milligl, do significantly better, whatever their cardiac stage. Highlights the importance of reducing that light chain production. There's also a renal staging system using urine protein and eGFR that predicts progression to dialysis. Many other biomarkers predict outcomes but aren't formally in the staging systems yet.
Let's talk treatment for AL amyloidosis, targeting the root cause, the plasma cells.
Urgency is paramount here. Multi-system involvement is typical. Median survival untreated, only 1-2 years. Current therapies target those clonal plasma cells, borrowing heavily from multiple myeloma treatments. Historically, oral melphalan and prednisone, not great. Rarely achieve deep remission or improved survival. Not used much now. Improvement. Swapping prednisone for dexamethasone, MDEX, better responses, more durable remissions. But dexamethasone can be tough, especially with fluid overload or heart issues. The big gun, high-dose melphalan with autologous stem cell transplantation, HDMSCT, can produce complete hematologic responses, wipe out clonal cells, normalize light chains in 40%. Organ function can improve 6-12 months later. Remissions seem more durable than in myeloma, some lasting over 15 years.
Wow, 15 years remission's amazing. But there's a catch.
Big catch. Only 20-30% of AL patients are eligible. Transplant-related mortality, TRM, is higher than for other blood cancers because patients are often sicker with organ damage. Amyloid cardiomyopathy, Poor nutrition performance status, multi-organ issues all increase TRM. Factor X deficiency, too, in 5–10%.
Yeah.
A big randomized trial actually failed to show a benefit for HDMSCT over MDEX, but the TRM in that trial was very high.
So patient selection is critical.
Absolutely essential. Careful selection and expert management are key to reducing TRM and making it work. What about severe heart involvement? Median survival untreated is only 6 months. In those cases, cardiac transplantation is an option, followed by HTMSCT to kill the plasma cell clone and protect the new heart. Now, for the majority who are transplant ineligible, oral NDEX was standard for years, but now regimens using bortezomib, a proteasome inhibitor, are generally standard of care.
Bortezomib. How does that work again?
It blocks the cell's protein disposal system, causing toxic protein buildup, especially killing plasma cells. But choosing the regimen depends on the patient. Bortezomib can worsen neuropathy. Certain genetics, like T1114, might make it less effective. In those cases, NDEX or combos with drugs like lenalidomide are options. High-risk patients, advanced cardiac stage II, severe heart failure, are the toughest group, needing very careful management. Newer agents, showing promise, especially for relapsed refractory disease. Oral proteasome inhibitor ixazomib, the anti-CD38 antibody daratumumab.
Daratumumab targets the plasma cells directly.
Exactly. Targets CD38 on our surface. Also, antifibril drugs, small molecules antibodies, are in trials trying to clear existing amyloid. Clinical trials are absolutely essential for progress here.
Okay, beyond killing plasma cells, supportive care is vital, right? Managing symptoms, quality of life.
Hugely important, whatever the amyloid type. Specifics. For nephrotic syndrome, swelling, diuretics, support stockings. Albumin infusions can help diuretics work better. ACE inhibitors. Use cautiously. Haven't shown benefit in slowing kidney disease here. For heart failure from amyloid cardiomyopathy, diuretics are key. But crucial warning digitalis, calcium channel blockers, beta blockers are relatively contraindicated.
Why contraindicated? That's different from normal heart failure.
They can interact with the amyloid fibrils, cause heart block, worsen heart failure. Very important distinction. Arrhythmias. Amiodarone can be used. ICDs. Maybe less effective due to thick heart muscle, but might help some. Atrial ablation works for AFib, pacing for heart block. Clot risk is high due to poor atrial contraction, so consider anticoagulation even without AFib. Autonomic neuropathy, midodrine for low blood pressure, motility agents for GI issues, and generally, nutritional support is vital, oral or IV.
What about localized AL, where it's just in one spot? Sounds like a totally different treatment plan.
Completely different. Deposits are from local plasma cells infiltrating airways, bladder, skin, etc. Treatment might be surgery to remove it, or low-dose radiation therapy, like 20G, to kill the local plasma cells. Systemic chemo is generally not appropriate. These patients need referral to specialized centers. Perfect example of why typing matters.
Okay, shifting gears to AA amyloidosis. This one's tied to chronic inflammation or infection.
That's the key link. Occurs with almost any chronic inflammatory state or infection. Think rheumatoid arthritis, inflammatory bowel disease, ankylosing spondylitis, familial Mediterranean fever, other periodic fever syndromes, or chronic infections like TB, osteomyelitis, subacute bacterial endocarditis. Persistent inflammation is the trigger.
But you mentioned it's becoming less common now, at least in the US and Europe.
Thankfully, yes. Incidence down to 2% in patients with those diseases, likely due to better anti-inflammatory and antimicrobial therapies. We're better at controlling the underlying conditions, but it can pop up in less obvious ways, too. Castleman's disease, lymphomas, renal cell carcinoma highlights the need for thorough workups, CT scans, etc., and in up to 30%, you can't find an underlying cause. Diagnosis of exclusion. Interestingly, it's the most common systemic amyloidosis in children, often linked to those inherited fever syndromes.
Pathology and clinical features for AA. What's the protein? Where does it hit?
The precursor is serum amyloid A, SAA, an acute phase protein made by the liver during inflammation. The amyloid fibril is made of an 8-kilodea fragment of this SAA protein. Usually takes several years of chronic inflammation, causing high SAA levels before fibrils form, though severe infections can speed it up. Organ involvement usually starts in the kidneys. That's a key difference from AL. Proteinuria, kidney failure. Later, liver enlargement, hepatomegaly, spleen enlargement, splenomegaly, autonomic neuropathy can occur. Cardiomyopathy is usually a late finding in 25%, often less severe than AL.
So if inflammation is the driver, treatment must target the inflammation.
Exactly. Primary therapy. Treat the underlying inflammatory or infectious disease vigorously. Suppress or eliminate it. SAA levels drop. Fibril formation slows or stops. Can sometimes even lead to partial regression of deposits. Specifics. Colchicine, 1.2 to 1.8 milli-GD is standard for familial Mediterranean fever. Very effective there. But important point, colchicine has not helped AA from other causes or other amyloid types.
Only for FMF, then.
Right. For other inflammatory causes, modern biologics TNF inhibitors, IL-1 or IL-6 antagonists can be very effective. They block the cytokine signals driving inflammation, cutting SAA production. Unfortunately, a drug designed to directly interfere with SAA fibril formation, aprocicate, failed in phase 3 trials. Targeting the fibrils remains tough.
Okay, let's talk ATTR and other familial amyloidosis, AF. These are inherited autosomal dominant, where mutated proteins misfold.
That's right. Generally rare globally, but certain founder effects like in Portugal, Sweden, and Japan mean much higher prevalence locally due to specific mutations spreading in those populations. ATTR amyloidosis, hereditary, is the most common hereditary form worldwide. Precursor, transthyretin, TTR, made mainly by the liver. Over 130 TTR mutations known, usually single amino acid changes, most cause clinical ATTR disease. Target organs, primarily peripheral and autonomic nerves and the heart. A key variant, V122I TTR, found in nearly 4% of African Americans and Afro-Caribbeans, strongly linked to late-onset cardiac amyloidosis.
So, should be considered in African American patients with unexplained heart failure and thick heart walls.
Absolutely, especially if there's no history of hypertension or valve disease, needs to be on the differential. Other familial AF forms exist, less common, from variant apolipoproteins AI, AII, gelsolin, fibrinogen AMA, lysozyme, and that newer one, ALYCT2. Leukocyte chemotactic factor 2, causes renal amyloidosis, especially in Hispanic Pakistani populations. No specific gene mutation found yet, interestingly, despite clustering.
That's the inherited side. But ATTRW wild type, age-related, that's the normal protein causing problems.
Exactly. Normal wild-type TTR can also misfold and form ATTR amyloid. Typically shows up in men starting in their 60s, becoming much more common with age. Used to be called senile systemic amyloidosis. Autopsy studies find it in 25% of hearts from people over 80. It's incredibly prevalent.
Wow, 25%. Why does the normal protein do this?
Not fully clear. Likely aging inefficiencies in the cell's quality control systems, the unfolded protein response, leads to secretion of TTR prone to clumping. The significance, huge. With aging populations globally, ATTRW is the most prevalent and fastest growing form of amyloidosis worldwide, a major public health issue emerging from molecular biology.
Clinical features and diagnosis for ATTR and AF, how do they show up?
ATTR has variable age of onset, variable severity. What looks like sporadic cases, no family history, often reflects incomplete penetrance, having the gene doesn't guarantee disease. Key presentations of HATR. Familial amyloidotic polyneuropathy. Starts as length-dependent small fiber neuropathy, feet first, then ascends. Burning, tingling, numbness. Also autonomic neuropathy. GI issues, dysphagia, diarrhea, vascular problems, orthostatic hypertension, ED, sweating issues, anhidrosis. And that interesting clue. Soft tissue disease often comes first, sometimes decades before nerve heart issues. Carpal tunnel, tendon problems, tendinopathy, spinal stenosis. Especially common in ATTRW, patients often report tendon ruptures, biceps, patellar, Achilles.
Tendon rupture years before heart failure. Fascinating link.
Really is. Less common ATTR signs. Vitreous opacities, eye, leptomeningeal deposition, brain from TTR made in the eye brain. Cardiac involvement comparison. ATTR heart disease is clinically better tolerated than AL. Survival much longer, untreated median 42-48 months versus 6 months for AL. Even though the heart might look thicker on echo at presentation, the deposits seem less acutely toxic.
And the syndromes for the other AF types, like fibrinogen, gelsolin.
Other AF types. Renal amyloidosis with mutant fibrinogen, lysozyme, apolipoproteins. Hepatic amyloidosis with ApoAI. And pathognomonic for gelsolin amyloidosis. Cranial neuropathy plus corneolytis dystrophy. Those lines in the cornea are a direct visual clue. Diagnostic challenges. AF can mimic AL clinically. Also, AF carriers can rarely get AL, or AF patients might have MGUS without AL. So, vital to screen both for plasma cell disorders and for mutations in amyloidosis patients. Mass spec might detect protein variations, but it's not designed to definitively ID mutations. DNA sequencing is the standard for AF mutations. This thoroughness is key.
Treatment for ATTR amyloidosis. Sounds like this area is exploding with new options. It truly is, rapidly evolving. Untreated survival is 5-15 years. 3 main therapeutic strategies now exist. 1, orthotopic liver transplantation, OLT, replaces the factory-making mutant TTR liver, only for ATTR. After 30 years, mostly limited now to ATTR patients with early peripheral neuropathy, especially the V30M type. Big limitation. Non-V30M patients often have progressive disease post-transplant because wild-type TTR from the new liver deposits on existing amyloid and heart nerves, so not a cure-all. 2. Stabilization of circulating TTR tetramers. Goal is to stop TTR breaking into unstable monomers that misfold. 2 agents, diflunisal, repurposed NSAID, and tafamidis, thyroxymimetic. Both bind TTR, keep it stable, slows nerve and heart disease progression. Proven in big phase 3 trials, diflunisal trial, ATTR, ACT trial. Tafamidis was the first FDA-approved drug for ATTR cardiomyopathy. Extends survival, slows decline, walking quality of life. But important note, doesn't seem to improve existing heart thickening or function. It mainly slows worsening.
So it stabilizes, doesn't reverse damage already done.
Right. Which leads to strategy 3, TTR gene silencing. Using RNA interference, RNAi, or antisense oligonucleotides, ASO, to suppress TTR production in the liver, stop the source, agents, patisiran, RNAi, and anodersen, ASO. These more reliably stop neurologic progression. And in 35–60% of ATTR patients, they actually improve sensory neuropathy, autonomic function, even cardiac systolic function. Truly revolutionary.
Improvement, not just stabilization. That's huge. The future looks incredibly bright for ATTR therapy then.
Absolutely. Rapid advancements. Phase 3 trials ongoing for TTR silencers in ATTR cardiomyopathy. Second-gen silencers being studied for even better effects. Next frontier, TTR gene editing, aiming to prevent mRNA production or correct the DNA mutation permanently. A potential one-time cure. Future challenges, though. As patients live longer, we need therapies that cross the blood-brain barrier to treat brain, leptomeningeal, and eye, vitreous amyloid, which come from local TTR production there. Current drugs don't reach well, but overall, it's a beacon of precision medicine.
Okay, let's quickly cover ATM amyloidosis, the one linked to kidney disease and dialysis.
Right. Composed of fine-tuned microglobulin, part of our immune system's MHC class I molecules. Normally cleared by the kidney, levels shoot up in end-stage renal disease, ESRD. Its size, 11.8 kiloday, meant older dialysis membranes couldn't filter it well, leading to accumulation over years of treatment. Good news. Incidence seems lower now with newer, high-flow dialysis membranes. Also, there's a rare hereditary form.
Clinically, it presents mainly with joint and bone issues, rheumatologic manifestations.
That's typical. Carpal tunnel syndrome, often the first sign. Persistent joint effusions, fluid buildup, mild discomfort, seen in up to 50% after 12 years on older dialysis. Usually large joints, bilateral, shoulders, knees, wrists, hips. Synovial fluid is non-inflammatory, confined 8-2M with Congo red staining. Also, spondyloarthropathy, spine arthritis, cystic bone lesions, less common, visceral deposits in GI tract, heart, tendons, subcutaneous tissues.
And treatment for A2M, anything specific?
Currently, no proven specific therapies to target the A2M amyloid itself. However, stopping dialysis after a successful kidney transplant may lead to symptomatic improvement. The new kidney clears the A2 microglobulin, stopping further buildup, maybe allowing some regression.
So the transplant treats the amyloidosis too, in a way.
Exactly. Unique situation.
Okay, so we've covered treatments that mostly limit the formation of amyloid proteins, stopping the factory, stabilizing the protein. But what's the next big idea? What about dissolving the amyloid that's already there, clearing the damage?
You've hit on the holy grail, really. The theoretical way to truly improve organ function isn't just stopping new deposits, but the disruption of existing amyloid. Targeting ubiquitous components of those tissue deposits. If we could clear the fibrils, maybe reverse organ damage, that would be transformative. Imagine undoing years of damage. The challenge, though, despite that huge promise, clinical trial validation for therapies designed to break down existing amyloid, it remains elusive. It's a massive area of ongoing research, a key challenge, a huge unmet need, lots of drug development efforts, but the home runs haven't quite landed yet.
It really raises the question, what breakthroughs are needed? What's just around the corner to finally dissolve these stubborn deposits? A fascinating puzzle with huge human impact. #HagOutro. Wow. What a journey through this incredibly complex world of amyloidosis. We started by getting that it's not one disease, but a whole group of protein misfolding disorders. The common thread, those extracellular clumps of insoluble fibrils messing things up. And you now know that understanding the specific precursor protein and its impact on organs is the absolute foundation for anyone wanting a truly sophisticated grasp of these conditions.
Absolutely. And let's recap those key takeaways, the things you need to remember to think like the pros. First, clinical suspicion is key. Watch for those red flags. Unexplained kidney issues, proteinuria, heart issues, diastolic dysfunction, neuropathy, GI problems, or the specific signs like macroglacia or raccoon eyes. Abnormalities in multiple systems. Think amyloidosis. Second, pathologic ID is fundamental. Congo red staining, usually on abdominal fat first. Seeing that apple green birefringence is definitive. Third, accurate typing is essential. Immuno, mass spec, genetics. Knowing the X and AX dictates therapy, cannot skip this step. Fourth, systemic amyloidosis is treatable. Antiplasma cell chemo, like bortezomib, is highly effective in AL. Targeted therapies are revolutionizing AA and ATTR. There's real hope. Finally, the future likely lies in combining therapies, stopping the precursor protein, and hopefully one day clearing existing amyloid. That holds potential for not just control, but real improvement in function and quality of life. And remember, for these rare diseases, tertiary referral centers offer specialized diagnosis and access to crucial clinical trials. These are the guiding principles.
Thinking about those incredible advances in gene silencing, even editing for ATTR, just mind-blowing stuff. It makes you wonder, doesn't it? What unexpected avenues might these molecular insights unlock for all protein misfolding diseases in the future? Alzheimer's, Parkinson's, cystic fibrosis, all stemming from similar basic protein problems. What could the ripple effects be? Definitely something to ponder.